Welcome to the third session of the Liver Health Project Echo Group. This was created to bring treatment and prevention best practices for non-alcoholic fatty liver disease, or NAFLD, now known as metabolic dysfunction associated steatotic liver disease, to non-liver experts. This session will be recorded, so please be sure to mute yourself unless you are asking a question. We love to learn a little bit about those who have joined us today. So to introduce yourselves, please add your name, location, and organization affiliations, and any other information you'd like to share with us in the chat. Our first speaker is Dr. Adam Buckholz. Dr. Buckholz is an assistant professor of medicine in gastroenterology and hepatology at New York Presbyterian Weill Cornell Medicine. The liver was the first organ he fell in love with in medical school, and his passion for gut and liver disease physiology and its management continues to this day.
Hopefully you guys can all see these slides, but I'm excited to be able to talk to you about the treatment and staging of MASLD. And thanks to the ALF for organizing this. So as was already mentioned, the term MASLD is a new one. The old disease NAFLD got a bit of a facelift, but for the most part, everyone who previously would have fallen under the NAFLD or NASH umbrella is now falling under the MASLD or MASH umbrella, which is an umbrella term that includes those who have steatohepatitis or inflammation, as well as those with bland steatosis, as well as those with more advanced or irreversible disease, all due to metabolic disease. And the diagnostic conditions, which we won't go over in a lot of detail today, include having steatosis on an imaging study, usually ultrasound, and at least one of these 5 metabolic criteria on the right-hand side. MASLD is now the most common liver disease nationwide and has rapidly become the leading cause of cirrhosis and indication for liver transplantation. So it's important that we understand how to manage it. So this talk is going to focus on staging of MASLD, as well as how to manage at each stage of disease. And conceptually, I like to think about fat in the liver or steatotic liver disease as a large bucket that holds about 35% of all Americans. Some small percentage of those will have alcohol-related liver disease, which is causing their steatosis, but the majority, about 85%, will be due to metabolic disease primarily. And about a quarter of those patients, they'll develop steatohepatitis, called MASH, or inflammation related to this fat. And about a quarter to a third of those patients will start to develop scar tissue related to this inflammation, and about a quarter of them will develop cirrhosis or end-stage liver disease. So really, there's this progressive process where you wind up with starting with a massive number of Americans, about 35%, and only about 0.5% of them will have very advanced disease, and 2% of them will have significantly advanced disease. However, this is going to get worse in the future. By some projections, by 2030, there will be about 3.5 million Americans living with cirrhosis or F4 disease due to MASLD. And another 10 or 12 million that have advanced fibrosis, which is more than doubling of the current rates of disease. So it is important that we be able to accurately risk stratify patients with disease, and staging is the most effective way to do this. The most common cause of death for that large bucket of people, the people with with steatotic liver disease, is still cardiovascular disease. And MASLD is an independent risk factor for cardiovascular disease. But as you can see in this graph on the right-hand side, as patients develop further and further fibrosis, they have a much higher relative mortality risk. And that's driven largely by an increase in liver-related mortality. So people who have more advanced disease, more advanced fibrosis, drastic increase in overall death, and it's related to increase in death, in liver-related deaths. So how do we decide what is the stage of disease in people? And this disease can be a little bit tricky because it's a clinical disease that has a pathologic diagnostic criteria. And we're not going to get too deep into the pathology of this condition, but on a biopsy, which is the gold standard for diagnosing MASLD, you'll see things graded in terms of steatosis and staged in terms of fibrosis. So those with less than 5% of hepatocytes having fat globules under a low-powered view have grade 0 or no steatotic liver disease, whereas each tertile, each third 5 to 33%, 33 to 66%, and 67% and up, increase the grade up to grade 3. There's also scoring systems to talk about extent of inflammation, but that's a little beyond what we're going to talk about today. And then more importantly, or more predictive of outcomes, is the stage of fibrosis. So those who have no fibrosis, of course, would be stage 0. And then those who have periportal fibrosis, which you can see by the blue stain for fibrotic tissue around the portal tract here, will have stage 1. Those who start to have projections in the periportal and perisinusoidal spaces will have stage 2 fibrosis. Those who have bridging between portal tracts down at the bottom left will have stage 3 fibrosis. And then in stage 4 fibrosis, it's the common final pathway for all chronic liver disease, which is regenerative scarred nodules called cirrhosis. So F4 disease is cirrhosis and generally felt to be irreversible. However, most of the time, we're not relying on these biopsy criteria to determine what stage of disease that people have. And almost always, non-invasive assessments or non-invasive tests, we call NITs, should precede a liver biopsy for risk stratification. Because you can't be biopsying 35% of Americans, we have to identify those at particularly high risk. And usually these tests can obviate the need to do a biopsy at all. As a general rule, the non-invasive tests that we're going to talk about are pretty good at ruling in high-risk disease and ruling out high-risk disease, but they sort of lose clarity in the middle stages and in between stages. So as this kind of simplified risk tool would suggest, the first thing that you should start with in office for staging patients is a FIB-4. FIB-4 is a fairly simple calculation, uses standard laboratory values, and essentially is the ratio of AST and ALT relative to the platelet count. So as the ratio of AST to ALT goes up, so too will the FIB-4. Additionally, age is contributory, and as platelet count goes down, FIB-4 will go up. A word, because sometimes it can be confusing, on using liver enzymes or ALT and AST to try to decide how severe someone's disease is. The problem is that ALT and AST are non-specific enzymes. They exist within the liver cells, and when you see them at high levels in the blood, it really means there's just increased cell turnover. But unfortunately, it doesn't necessarily mean there's inflammation, and certainly not inflammation due just to fat. They also naturally decrease with age, and as fibrosis gets worse and hepatocyte function worsens, you may actually see them go down paradoxically. They also increase with BMI, so it can be tough to interpret. All the time, we'll have young patients with fairly early disease, but because they're young and very obese, they'll have very high liver enzymes. And unfortunately, as you can see by the graphs on the right-hand side, these are areas under the receiver operating curve, basically looking at the sensitivity and specificity of using ALT and AST to find more advanced disease. You can actually see that, for example, those with advanced fibrosis are more likely to have a normal ALT. So it's basically like a coin flip if you're just using ALT and AST. There is another laboratory test called the ELF test, which has been approved. It's very easy to get through Quest or LabCorp. It's a send-out test. And it's basically, we recommend that you use it as sort of a binary predictive tool. Values greater than 7.7 predict more significant fibrosis and should prompt a referral, while those less than 7.7 infer a low risk of advanced fibrosis. More common in specialty settings would be to use image-based risk assessment. The most common one that we use day-to-day in clinical practice is FibroScan, or vibration-controlled transient elastography, but there's also ultrasound elastography and MR elastography, and essentially what these are doing is they're putting a mechanical wave through the liver and seeing how stiff it is, how resistant to that wave the liver is. They can typically be performed outpatient, and FibroScan in particular is very affordable and has almost universal insurance and approval. It should be noted that patients with significant inflammation, the inflammation can be misinterpreted by the FibroScan as stiffness. And so for patients with very elevated liver tests, you should avoid using FibroScan as an upfront option. And frankly, if you're considering fatty liver in patients with very elevated liver tests, perhaps you should make sure that there's not other conditions going on at the same time. There's also reduced accuracy of FibroScan in the setting of the morbidly obese, which can be an issue when you're dealing with patients with significant metabolic disease. That said, it is still a very good screening test that we use every day. And it attempts to approximate both the grade of steatosis and the stage of fibrosis. So you can see on the right-hand side, and I think we'll go through this a little bit more in the case studies, but this particular patient, on the left-hand side, you can see 362, which would correspond to a high grade of steatosis. And on the right-hand side, 4.4, which, as you can see based on the scale that I put here, would suggest that somebody's at low risk for having significant fibrosis. So those less than 8, low risk, those greater than 12, high risk, and 8 to 12 is in between. As I said, there's some loss of sharpness between the stages and in the middle of all of these tests. Almost always, it's important to use clinical reasoning when interpreting these sorts of scores, and the diagnostic yield of each score is going to improve when you combine it with another. For example, FIB4 plus the ELF score, or FIB4 plus a FibroScan, FibroScan plus an MRE. There are lots of settings that it's important to be aware that FIB4 may perform worse. For example, there are adjustments to the interpretation of this score in those who are younger than 35 or older than 65, because age is part of the calculation. For example, in those older than 65, the threshold should be different. Now, if you're using MD Calc or something like that to try to find the score, they should mention these adjustments, but you should just be aware that the accuracy does decrease at the sort of standard thresholds in those outside of those age ranges. People with HIV can have falsely elevated FIB4 tests, and those, as I mentioned, with very elevated liver tests, the accuracy decreases. Generally, we're able to reserve biopsy for people who don't have agreement between their NITs, or if there's still diagnostic uncertainty, whether this is truly due to fatty liver or rather autoimmune hepatitis or some other condition, or if they're screening for a clinical trial. Biopsies are tough because it's an imperfect gold standard. It's a big liver and you only take a little piece, so there's high risk for sampling error. There's also a lot of variability between how pathologists interpret various biopsies. And of course, there's significant cost and discomfort. And a word on cost, on the right-hand side at the bottom, you can see several of the common non-invasive tests that we use, graphed relative to their overall accuracy on the left, on the y-axis, and their cost on the x-axis. So MRE is generally felt to be the most accurate of the non-invasive tests, but does tend to cost more, so it shouldn't usually be a first-line test, whereas FIB4 is less accurate, but tends to be very, very cheap. And VCTE, which is FibroScan, and ultrasound elastography right next to it, are somewhere in the middle. So what do you do with someone once you've diagnosed them with MASLD and properly staged them? Well, there are some universal things that I would recommend you do with every patient, regardless of stage. So first, you have to decide, do they need to be referred? So anyone who has cirrhosis on imaging or clinical signs of advanced liver disease, such as ascites or spider angiomata, encephalopathy, these people should be referred to see a hepatologist up front, preferably at a transplant-capable center. In those who have inconclusive fibrosis assessments or you believe have advanced fibrosis, high risk for advanced fibrosis based on the non-invasive testing, they should all be referred. It's critical to make sure that the patient understands the diagnosis and that they do need to follow it, because it's a tale as old as time that we'll have patients that come and say, well, maybe I knew that there was some fat in my liver, but they said it was no big deal, or that it simply wasn't mentioned, but there's imaging from years before showing steatosis. In all patients, they'll probably benefit from lifestyle optimization, which we'll discuss in more detail. And then for those who have diabetes or 2+ metabolic risk factors, they should be repeating non-invasive tests every 1 to 2 years. For those who don't have diabetes and only 1 or 2 or 0 or 1 metabolic risk factors, you probably can wait to every 2 to 3 years to repeat something like a FibroScan. And as I mentioned before, some people kind of have the misnomer that bland steatosis or steatosis without fibrosis is benign. And for that we can sort of try to remember the rule of threes. So there's a lot of variability in terms of who will have progressive disease. It's based on a lot of factors. But if you took 100 people, as they basically did on the right-hand side here, About 25% of them had inflammation, and about 3/4 of them had bland steatosis. And you watch them and rebiopsy them years later. In this case, it was a follow-up of 7 years. A little more than a third will progress, a little more than a third will stay stable, and a little less than a third will have regression of their disease state at the time of biopsy. Diabetes and obesity are the metabolic conditions that most predict disease progression, and the rate of progression varies a lot based on genetics, how much inflammation is present at time of diagnosis, and other environmental factors, but give or take about 5 to 15 years per stage, meaning that in most patients, it's going to take 20 plus years to progress from bland steatosis to advanced disease, but that's why it requires monitoring every couple of years. Alcohol is a common thing that we universally need to talk about with all patients who have fatty liver, no matter where they are on the spectrum. And this is a good time to mention that there is a new condition that came out of this name change from last year. It's called MASLD, which, while it doesn't roll right off the tongue, does kind of make sense. This is America, and there are plenty of people who have both metabolic risk factors as well as alcohol misuse. So for people who have metabolic risk factors, and in women drink 2+ drinks a day, or in men drink 3+ drinks a day, they may have a synergistic disease called MASLD. Alcohol use is known to synergistically increase the risk of cirrhosis, death from liver disease, and liver cancer. And I usually will counsel patients that alcohol is, regardless of stage of disease, the wrong type of nutrition, generally consumed with the wrong types of foods at the wrong type of day. And so almost certainly they benefit from reducing or eliminating alcohol. But in those without fibrosis, we do tolerate a minimal amount of alcohol use, so never any binge episodes and fewer than 7 drinks a week. While in those with significant fibrosis, they should discontinue alcohol altogether, certainly until their fibrosis regresses. Weight loss has been the mainstay of disease management for more than a decade now. And that's based on data over here on the right-hand side that shows that even moderate amounts of weight loss can improve outcome in fatty liver disease. Right now, there are varying recommendations, but as useful, easy to remember thresholds for those with bland disease, losing about 5% of total body weight seems to improve histologic findings, and in those with fibrosis, a more aggressive target of about 10% of body weight. It's important, as you can see on the right-hand side, this is one of the more important studies that showed that weight loss helps with treatment of disease. But if you look at any particular marker of improvement, for example, fibrosis improvement down in the far bottom right, there are people who lose weight and don't have fibrosis improvement, as well as people who do lose weight or who don't lose weight and do have improvement of their fibrosis. So it's not perfect for everyone, but it's definitely one of the most effective treatments that we can offer. And then we should briefly mention lean MASLD or lean MASH. This is a well-known condition. About 4% of Americans are felt to have this, and up to 19% of Asians due to genetic predisposition. This is steatotic and metabolic liver disease in those who are non-overweight. Regardless of the fact that they're not overweight, they still generally benefit from diet and exercise optimization, as well as a more moderate weight loss target of about 3 to 5% of their body weight. And in all cases, there should be an emphasis placed on going slow and maintaining the weight loss rather than rapidly crashing and losing weight loss very quickly. So we aim for about 0.5 to 1 pound a week of weight loss. So diet, of course, a mainstay of weight loss. Which diet is the right one? We're not going to go into a lot of detail on diets in fatty liver specifically, but generally there are 3 main types of diet, and every diet includes some combination of reducing quantity of food, changing the composition of food, or changing the timing of eating. In general, the Mediterranean diet is the most often recommended, and that's in part because of its known cardiovascular benefits, remembering that the leading killer in fatty liver is actually cardiovascular disease, but also the macronutrient composition, lower in fructose and processed carbohydrates, processed meats that tend to increase steatosis deposition. Additionally, 3 cups of coffee a day, and then if they don't drink coffee, drinking green tea, not green tea extract, may also provide some of the same benefits. is actually in our guidelines now to improve hepatic steatosis. Otherwise, we don't generally recommend supplements. Milk thistle or Silmarin is a common one you'll hear about. There is no randomized controlled data that suggests that it's beneficial in fatty liver particularly, but there is some sort of smaller, less controlled data that it's helpful. And it does seem to be safe when taken at recommended dose. So I don't actively discourage patients from taking milk thistle who are interested in it. Generally speaking, though, of course, whichever diet helps a patient sustainably lose weight is probably the right one. There's a lot of interest right now in, for example, intermittent fasting in treating patients with fatty liver disease. And there is a lot of evidence that it may be helpful. But in those with, for example, insulin-dependent diabetes, it may not be the appropriate dietary choice. As far as exercise, I have to say our guidelines are not particularly helpful. They recommend increasing exercise to the maximum extent possible, which is something I should probably do too. But that said, when they get slightly more specific, they do recommend 150 minutes of exercise over at least 5 periods a week, which is about 30 minutes a day, 5 times a week, or increasing from baseline by about 60 minutes. And that's based on data that suggests that the more vigorous exercise you do, the better the improvement in fatty liver. One helpful thing is that this exercise can either be resistance training or aerobic based, and the benefit does seem to be independent of weight loss. There's something about the metabolic stress of exercise that seems to improve fatty liver disease. Briefly, it is important to control metabolic comorbidity. So this is patients that were put on insulin, which usually causes weight gain, if anything, but even controlling the diabetes with insulin does result in reduced fat in the liver. This is patients that were put on statins to control hyperlipidemia, and you can see over time the ALT does go down. So it's important to remember to control the metabolic comorbidities, which may help improve the disease and certainly will reduce their risk of cardiovascular mortality. And then briefly, we should talk about statins. Statins are safe and they are recommended even in advanced liver disease. So we're not going to get too much into the theory of liver injury, but there is a lot of fear, I think, in community practice in using statins in patients with liver disease. But in the vast majority of patients, they get exposed and they'll adapt sufficiently to the drug. So even if they see a mild increase in liver enzymes briefly after starting statins, they will over time adapt. Their liver will stop having inflammation related to the drug, and only a very small fraction will have insufficient adaptation and a clinically significant liver injury. The rate is thought to be about 1 in 2 million in patients on statin use. So use statins in these patients and consider discontinuation only if liver enzymes are sustained above 3 to 5 times the upper limit of normal. So for patients with high-risk disease, time is a little bit more of the essence. We do have higher weight loss targets, as we talked about, and a lower threshold for medication or surgical management. If you have access to a dietitian, I certainly would have anyone with F2 disease or higher see a dietitian to try to optimize care. And those with F3 or 4 fibrosis should also probably be enrolled in hepatocellular carcinoma screening programs. Now, they're getting referred already anyways, but these are patients that are actually at increased risk of HCC, even without cirrhosis or decompensated disease. And then you could consider whether getting them enrolled in a clinical trial for a liver-directed therapy or getting them started on resmetirom might be helpful. And then they should get annual monitoring of disease progression. As far as treatment options for those with more advanced disease, weight loss surgery is probably the most effective tool we have for reducing fibrosis, at least with a significant amount of evidence. So several long-term cohort studies do suggest that bariatric surgery can result in sustained improvement in scar tissue, even in those who later regain weight. So you can see in those who had significant BMI change after bariatric surgery, greater than 90% of them had resolution of steatohepatitis on follow-up biopsies. And even in those who regained some weight, 5 years later, there was significant improvement in the level of fibrosis in those who had previous fibrosis. Unfortunately, there's no good prospective randomized data. Usually we're dealing with case series or cohorts. And there's growing evidence that endobariatrics or endoscopic bariatric procedures may achieve similar results. So stay tuned for that. But at present, the guidelines don't recommend bariatric surgery just for fatty liver disease, even with fibrosis. However, in future, this may change. And certainly those who already have an indication for bariatric surgery and do have fibrosis, you should strongly consider it. Some older drugs that have been used for treatment of steatotic liver disease include pioglitazone, which is a PPAR gamma activator. It's an old diabetes drug and does improve lipids. And based on the data from the Pivens trial, which we won't go into today, but was a big New England Journal study from more than a decade ago now, it does seem to improve NASH histology, but unfortunately there are significant side effects, including weight gain, osteoporosis, and risk of heart failure exacerbation. So that's really limited its practical use, both for diabetes and for fatty liver care. Vitamin E is largely safe. The dose is 800 units a day. The drug that they used for the study was just nature-made over the counter. And it's usually sold in capsular form. There is a theoretical risk, increased bleeding risk on vitamin E, and there's conflicting data about prostate cancer risk. So I don't use it in patients with a previous history of prostate cancer, but otherwise largely a safe thing that could be tried in patients. That said, we've sort of moved beyond that in routine clinical practice. Of course, I don't need to tell you about GLP therapy. It's hard to turn on the TV without seeing things about it. It does improve, of course, lipids, improves insulin sensitivity, and induces weight loss and improves cardiovascular outcomes, all critical endpoints in this condition. Currently, use is limited by expense, availability, and of course, GI side effects. There's also significant weight rebound, which you can see on the right-hand side here in those who discontinue therapy. There is ongoing research as far as its actual impact in more end-stage fatty liver disease, but thus far, there's no data to suggest that it actually improves fibrosis. This on the right-hand side was a sort of disappointing phase 2b study from a couple of years ago, suggesting that in those who took semaglutide weekly, there was no improvement over placebo in terms of fibrosis regression. And then finally, there is resmetirom, which is the new kid on the block. It's an oral liver-directed thyroid hormone receptor beta selective agonist. So it's a different thyroid hormone receptor than is met by like levothyroxine, typical thyroid hormone activity. In MASLD, this beta receptor activity is reduced, which leads to impaired fatty acid oxidation and inflammation. It's a nice easy dosage form, which is 80 milligrams or 100 milligrams for those who weigh over 100 kilograms. It received conditional FDA approval in March, and certainly there are ongoing studies and long-term data has to be there, but the data for 1 year is on the right-hand side. In placebo, about 10% of patients had NASH resolution without worsening of fibrosis, and 25% had improvement in the resmetirom group. And then only 14% had regression of fibrosis, whereas 25% in resmetirom. So is it a perfect drug, a wonder drug? Unfortunately, it is not, but it does represent significant improvement in the first liver-targeted therapy that we have for those with fibrosis. At this point, most people prescribing it are specialists, but you should know that it does affect the doses of statins that people can be on. It induces the same enzyme as statins, and so patients that are on atorvastatin or Crestor just know that there is those maximum doses that you can see on the side. The GI side effects tend to be the most notable of the side effects, but in our experience, they tend to resolve after about a month of treatment. So finally, in conclusion, this is a complex disease. It's often clinically silent, but it's really important to accurately stage it because of its increasing prevalence, its outsized role it's going to play in the future of end-stage liver disease. Those with F2 disease have increased risk of mortality driven specifically by liver disease, while everyone is at increased risk for cardiovascular disease. Using non-invasive tests and then selective use of liver biopsy can help to risk stratify and decide who needs more intensive care of that massive 35% bucket. Everyone should get lifestyle modification, should work on risk alleviation, but that's especially important in low-risk disease, while medication, surgery, and aggressive multidisciplinary intervention should be used in those with high-risk disease. And then for those who have cirrhosis or decompensated disease, really they should be getting a liver transplant evaluation. So given the rising prevalence, this is a huge topic of current clinical research and investment in the pharmacology space. There's a lot of ongoing late-stage clinical trials, which you'll hear more about over the coming years, so stay tuned. With that, I will turn it over and we will do some case studies. I'll stop sharing my screen. And then if you have any questions, go ahead and put them in the chat. I'll take a look at them while we're going through the case studies, and then we'll talk about them in the Q&A at the end.
All right, next up, we'll move into our case study portion. Today's case study will be presented by Dr. Maya Balakrishnan. Dr. Balakrishnan is an associate professor of medicine in the section of gastroenterology at Baylor College of Medicine and an NIH-funded MASLD researcher. She practices gastroenterology at Ben Taub Hospital with a special focus on the management of liver disease.
All right. Well, good morning or good afternoon, depending on where in the United States you are. I'm going to be putting into practice what Dr. Buckholz just reviewed for MASLD by navigating you through 3 patient cases. But I'll start with a couple of concepts, just highlight some concepts that came up during his talk. First, MASLD, as he presented, is really a hepatic complication of metabolic syndrome. So it's steatosis in the liver that develops because of obesity, because of increased fatty flux to the liver due to obesity or because of insulin resistance. So it's very tightly correlated with having metabolic syndrome. And as such, patients who have MASLD are at risk for developing multiple systemic complications. And almost all of these are mediated by obesity or metabolic syndrome. But the 2 complications that we're particularly concerned for in MASLD are these: cardiovascular disease and liver complications, because these represent 2 of the leading causes of mortality in MASLD. So patients with MASLD, they face what we call competing mortality risks from cardiovascular disease and from complications of cirrhosis. So when we think of the patient with MASLD, the goals of our clinical management are, 1, to reduce the risk of cardiovascular complications, and at the same time, reduce the risk of progression to liver complications. With regard to reduction of cardiovascular risk, at this time, the way we approach that in patients with MASLD is per standard of care, the way you approach this in any patient with or without MASLD. So it's recommended now to follow routine management guidelines with regard to cardiovascular risk assessment and management. Where things become a little more unique in patients with MASLD is how we think about reducing the risk to progression to liver complications. And that's where we think about staging and treating according to stage of the liver disease in MASLD. So we're going to navigate 3 cases, pretty typical cases that'll come through your practice, and talk about how to stage each of these cases and how to approach treatment based on the stage of MASLD these patients have. The first is a 40-year-old woman with abnormal liver enzymes for 5 years. Second, a 55-year-old man who has type 2 diabetes and historically always normal liver enzymes. And third, a 57-year-old woman with hepatic steatosis discovered incidentally. And these are my learning objectives for you. So among these patients and any patient who comes through your office, I'm hoping that at the end of this, you understand whose liver you need to worry about. You can determine whether the patient with MASLD in front of you needs a hepatologist, and then understand what can be done to reduce the risk of liver-related morbidity and mortality in this patient with MASLD in front of you. So let's start with case number 1, the 40-year-old woman with abnormal liver enzymes. So she's coming in today for an annual health check. And in terms of her medical history, you see that she has prediabetes, she has hypertriglyceridemia, she takes metformin, she doesn't drink any alcohol, doesn't smoke. On exam, what's notable is her body mass index meets criteria for obesity, it's centrally distributed, she has acanthosis nigricans, suggesting insulin resistance. Now, you review her labs. She's been in the same healthcare system for a number of years, and you see consistently since 2019, she's had elevated liver enzymes. These are an hepatocellular enzyme pattern, meaning the ALT and AST are predominantly elevated at 90 and ALT 90, AST 60. They fluctuated over the years, but they've been consistently elevated. And she has had an ultrasound of the liver done that you can see. And her liver is a little large, it's 17 centimeters. And the radiologist is describing increased echogenicity suggestive of steatosis. So the first question here is, does this patient have MASLD? You might be tempted to quickly say, yes, she has MASLD, she has metabolic criteria and steatosis. But we're going to talk about the steps you need to take to prove that to yourself. And then you have to determine the cause of her abnormal liver enzymes and figure out whether those abnormal liver enzymes are really from MASLD or from something else. So first, does she have MASLD? So something conceptually to keep in mind is that MASLD is one of several causes of steatotic liver disease. So steatosis or fat in the liver is basically a sign of some kind of liver injury, and there's something that's driving it. And metabolic syndrome, obesity, insulin resistance is one thing that causes steatosis to accumulate in the liver. But there's many others. Alcohol is the other very common one. And then there's other more unusual diseases, some genetic diseases and medications that can also drive steatosis. And conceptually, it's also important to remember that there can be more than one cause of steatosis in a patient. It can be metabolic syndrome and alcohol-related liver disease called MASLD, which Dr. Buckholz mentioned. So we need to prove to ourselves that this patient's steatosis is truly driven by metabolic syndrome and it's from MASLD. How do you do this? So if you have a patient with some evidence of steatosis in their liver, the first step is to determine whether they meet any cardiometabolic criteria. That's just a fancy way of saying, do they have any one of the 5 features of metabolic syndrome? All the typical features of metabolic syndrome, do they even have one of them? If they do, then you can conclude that this patient has metabolic dysfunction-associated steatotic liver disease. They have MASLD, but you also have to make sure the patient doesn't have another cause of steatosis in their liver driving the steatosis, because that would change management. So the other common one being alcohol. This patient doesn't drink any alcohol, so the steatosis is most likely entirely driven by MASLD. But you also need to make sure her abnormal liver enzymes are not driven by another cause. And that requires a basic workup for alternative causes or concomitant causes of abnormal liver enzymes. And this is a differential diagnosis in the left column of elevated hepatocellular enzymes. The causes include viral hepatitis, and then less commonly things like hemochromatosis, autoimmune hepatitis, Wilson's disease, alpha-1 antitrypsin deficiency, and then various forms of drug-induced liver injury. So what I have on this slide is a basic workup that you need to send in any patient with abnormal liver enzymes. These are all tests that would then, if they come back as abnormal, they would then trigger further workup or referral to a hepatologist. But that in any patient with abnormal liver enzymes, whether or not you think they have MASLD, this needs to be done as a first pass. In our patient, her workup for abnormal liver enzymes comes back as completely negative for hepatitis C, hepatitis B, and then the more rare causes I mentioned, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency. You have an ultrasound showing hepatic steatosis. Very important, you've done more history taking and you don't see that she's been exposed to any new medications over the past 6 months. So in this patient, you can conclude that her abnormal liver enzymes are therefore entirely from the MASLD. She meets criteria for MASLD and she doesn't have any other cause for her abnormal liver enzymes. So you're dealing with MASLD and MASLD only here. So the next step to figure out is, does this patient with MASLD have severe fibrosis? And this is a slide that Dr. Buckholz shared. It's a fibrosis risk stratification algorithm from the ACE guidelines, the endocrine guidelines. And it lays out how you approach this. You start with a FIB4, And based on the FIB-4 test, then you make some decisions about whether the patient needs an immediate referral to hepatology, whether they can stay in the primary care clinic, or whether they need another test to figure out whether they have stage 2 fibrosis or more. So why is this important? Just to review what Dr. Buckholz just explained, this is the natural history of MASLD. So when the normal liver is exposed to insulin resistance or obesity, the first thing that happens is steatosis accumulates. That steatosis can then lead to inflammation in the liver and progressive liver injury. That progressive liver injury drives fibrosis. Fibrosis can progress over time. It can grow from stage 0, which means no fibrosis, to stage 1, which is minimal fibrosis, stage 2, 3, and culminate in stage 4 fibrosis or cirrhosis. And that's when people's risk for complications like cancer in the liver and decompensations like ascites and esophageal varices, the risk of those entities increases once someone develops cirrhosis. So in the research that's been done, and Dr. Buckholz showed this same data, the research that's been done, it's been found that it's patients who have stage 2 fibrosis or more at the time of evaluation, those are the patients who are most at risk for ultimately succumbing to complications from liver disease. Hence, when we see patients with MASLD, we want to know if this patient in front of us has stage 2 fibrosis or more. And the way we do that is using the non-invasive tests like the FIB-4 elastography and the ELF test shown in that algorithm. So coming back to our patient, we do the FIB-4 test, which you can just pull up on your phone or on the internet, and her FIB-4 comes back as 1.15, which is below the threshold of 1.3. So people who have a FIB-4 score of less than 1.3 are highly unlikely to have severe fibrosis. The way we interpret this is at this time, she's at low risk for progression to cirrhosis. So this is a patient that you can manage in the primary care clinic. You do have to counsel her about weight loss. As mentioned in the previous presentation, weight loss is indicated for sure in all patients with MASLD. The threshold of weight loss we would counsel in this patient is at least 5% body weight loss. And that's the threshold of weight loss that's been associated with reduction in the degree of hepatic steatosis. This patient, like any patient with MASLD, needs routine cardiovascular disease risk management per guidelines. And this is a patient where you should reassess her fibrosis stage in 2 years. That means it's the year 2024 right now. In the year 2026, you should do a FIB-4 score again and see whether whether she's has a low FIB-4 or something higher requiring further workup and referral. So let's move on to the case number 2. This is a 57-year-old woman with hepatic steatosis discovered on ultrasound. So she recently went to the ER for postprandial right upper quadrant pain. While there, she had an ultrasound done and a workup done. It concluded that she had gallstones. She was eventually sent for a cholecystectomy. But now she's here in your primary care doctor's office, and she's asking you, what's the significance of the hepatic steatosis they saw on her ultrasound back from that ER visit? So let's review her history. She too has metabolic features, metabolic syndrome features. She has 2 of them. She has hypertension and type 2 diabetes. These are the medications she takes for these conditions. She drinks a glass of wine every month or so. Her BMI meets criteria for being overweight. And you review her labs and you see that she's had normal liver enzymes persistently. It's always been normal for as long as checked in your healthcare system. You look at that ultrasound from the ER before her gallbladder was removed, and you see, yeah, she has a mild hepatomegaly, and she does have steatosis in the liver. So does she have MASLD? Well, we have to go through this algorithm again. So she has hepatic steatosis seen on the liver ultrasound. So check, yes, she has steatosis. Next question is, does she meet any of the metabolic syndrome criteria? Yes, in fact, she had 3 of them: hypertension, diabetes, and a high body mass index. So, yes, she meets criteria for MASLD. She doesn't drink a significant amount of alcohol. So alcohol is probably not driving this liver disease. And she doesn't mention she's taking any new medications or anything like that. So this is a patient where you can conclude that, yes, she has MASLD. In this patient, you do not need to send off the same workup that you did in the previous patient, like hepatitis C antibodies, hepatitis B serologies, things like that, because she has normal liver enzymes. So that's not indicated in this patient. It would be if she had elevated liver enzymes. However, just like the previous patient, again, she's someone with MASLD, you have to figure out, does she have severe fibrosis? Again, we are case finding. We are looking for the patient with MASLD in front of us who has stage 2 fibrosis or more, because they're the ones most likely to succumb to complications from liver disease and need extra intervention. So again, we're going to start with the FIB4 per this algorithm, depending on the FIB. If it's less than 1.3, they would be deemed low risk, stay in the primary care clinic. If the FIB4 is more than 2.67, they're deemed to be high risk for severe fibrosis, and they would be referred to a hepatologist. If their FIB4 is somewhere in the middle, 1.3 to 2.67, you just don't know the answer. And that patient is considered to have indeterminate risk, and they need a second non-invasive test, a liver stiffness measurement by elastography like FibroScan, which was mentioned in the previous presentation, or an enhanced liver fibrosis test, which is that send-out test. So let's see what happens to our patient. So her FIB4 comes back at 1.42. So it's indeterminate. You don't know. You can't definitively rule out severe fibrosis. You can't rule in fibrosis. So you need a second test. That second test is either a FibroScan, if you have access to it, or an ELF blood test, which is a blood test. So this patient gets ultrasound-based elastography via FibroScan, and her liver stiffness measure is 10. So she has, so if we go through this algorithm, a liver stiffness measurement less than 8 means someone is unlikely to have severe fibrosis. A liver stiffness measurement of more than 12 makes it very likely they have, more likely that they have severe fibrosis. A liver stiffness measurement between 8 and 12 means you don't know. You can't rule in severe fibrosis. You can't rule it out either. So the recommendation is in anyone with a liver stiffness measurement more than 8, where, 8 to 12, where you just don't know, or high risk for severe fibrosis, all of those patients need to be referred to a hepatologist for additional workup to figure out how much fibrosis they have. So what happens to this patient? So the interpretation, like I said, is possibly she has severe fibrosis, but we really don't know because her liver stiffness measurement is between 8 and 12. So potentially she has increased risk of progression to cirrhosis. So this is a patient who definitely needs referral to a hepatologist to definitively determine her fibrosis stage and titrate treatment accordingly. So you put in the referral. Meanwhile, there's things you can do in the primary care clinic. You should definitely counsel a patient to lose weight, start working with them on their diet, calorie restrictions, change the quality of what they're eating, start counseling them on increasing their physical activity, encourage her to abstain from any alcohol drinking because we're not sure how much fibrosis she has at this point, and she needs the standard cardiovascular disease assessment and management. So what happens at the hepatologist? You send her off. What's happening now? What's the hepatologist doing for her? Well, this is what the hepatologist is going to do. They're going to reevaluate the liver disease, rule out the possibility of concomitant liver disease etiologies. They're going to repeat the same non-invasive tests you did, and the results come back exactly the same. So now the hepatologist is at a point where they have to definitively decide whether or not this patient has severe fibrosis. So at the hepatologist's office, what they may do is refer the patient for a liver biopsy. This is the patient we would choose to send for a liver biopsy. That's done and it's found that she has stage 3 fibrosis. So she has severe fibrosis. She's one stage before having cirrhosis. So these patients are at risk for progressing to cirrhosis anywhere from 2 to 7 years, depending on a number of factors. So the treatment in this patient is she needs a higher threshold of weight loss than our first patient, because now we are dealing with the patient with advanced fibrosis. So the recommendation is 10% weight loss, because that's associated with fibrosis improvement. The other thing this changes is this is a patient that you would now target with a liver-directed therapy, a therapy to try and reduce how much fibrosis she has in her liver, how much steatohepatitis she has in her liver. And this would be a patient who's a candidate for resmetirom, the new medication that was mentioned recently approved by the FDA. Resmetirom is associated with about 30% of these patients had improvement in their fibrosis. So we would try this medication for at least a year in this patient. So let's move on to our third and final case. This is a 55-year-old man with type 2 diabetes. So he's coming into your office for routine management of diabetes. He has no history of liver disease. And his medical history, you see, is notable for hypertension. He also has peripheral vascular disease. These are his medications. He takes metformin, semaglutide, Lipitor. He does drink a couple of beers a week. His BMI classifies him as having obesity. It's centrally distributed. He has signs of insulin resistance. And you look at his liver enzymes, and you see historically, they've always been normal, but I will just point out a couple of things. The AST is a little bit higher than the ALT, and his platelets are low. You don't have any abdominal imaging, but right there, the low platelets might make you start thinking that this patient may have cirrhosis. Platelets under 150,000, you start to think about that. But this patient, you might be wondering, like, why am I even bringing up MASLD, right? I mean, he's historically had normal liver enzymes. I don't see any ultrasound with steatosis in this patient. Like, why am I talking about this? Well, this is why. So population studies have shown that MASLD prevalence is really high in the general population, but it's really high in people who have obesity and type 2 diabetes. And there's a high prevalence specifically of MASLD with severe fibrosis. So the guidelines say anyone who's high risk for MASLD and severe fibrosis, just go ahead and screen them for severe MASLD fibrosis. So they enter this algorithm, this patient enters this algorithm right here. This is a patient with type 2 diabetes. So you automatically run a FIB4 in this patient, and you go through this algorithm accordingly. So what happened to this patient? So his FIB4 is 3.32. So he is high risk for potentially having severe fibrosis. And in fact, his findings suggest cirrhosis, especially given that low platelet count. So this is a patient who is at risk for liver decompensations, liver failure, hepatocellular carcinoma, and he absolutely needs a referral to a hepatologist. Meanwhile, what you can do in the primary care clinic is tell him to abstain from alcohol drinking, those 2 beers a week. I would encourage him not to use it anymore. He needs cardiovascular disease risk management. And I think you should just go ahead and get an ultrasound of the right upper quadrant, an AFP every 6 months for hepatocellular carcinoma screening, given that he has cirrhosis. So what happens to him in the hepatologist? So he shows up at the hepatologist's office. They'll review his ultrasound that you got and see he has a nodular liver with splenomegaly, confirming cirrhosis. So the hepatologist now is really concerned about his progression to decompensated liver disease and HCC. So the management in the hepatologist's office is to screen for HCC every 6 months, which is indicated in anyone with cirrhosis, including MASH cirrhosis. Screen for varices every couple of years. And then the treatment is moderate weight reduction, but we also want to maintain his muscle mass. And the other thing I'll bring up is that there are no pharmacotherapies available for MASH cirrhosis. So the resmetirom that we used in the For second case, the lady with stage 3 fibrosis, that is not something we can use in patients with cirrhosis because the safety is not clear. And secondly, there's no data to support its use at this time. So unfortunately, there's no MASH-directed therapies that we can use for cirrhosis. So here's a summary of our 3 patients. We started off with this lady, this patient, woman, 55-year-old woman with abnormal liver enzymes. You worked up the cause of her steatosis, you worked up the cause of her liver enzymes, and in the end, it was all MASLD. You staged her. She did not have severe fibrosis. She's someone you can manage in your primary care clinic. Encourage weight loss of 5% from baseline, and she, at this time, MASH-directed pharmacotherapy not indicated. But you have to re-screen for severe fibrosis in 2 years. The second was this 57-year-old woman, incidental hepatic steatosis seen. Despite the normal liver enzymes, you stage her fibrosis using the FIB4, and that led to a path down a path that ended up with a liver biopsy showing stage 3 fibrosis. She's someone who needs more weight loss and needs MASH-directed pharmacotherapy. And the last case is a routine screening patient for MASLD fibrosis, someone with type 2 diabetes. And surprisingly, he ends up having MASH cirrhosis, so the most advanced of all 3 patients, and he needs management of cirrhosis. So with that, I'll leave you with my key points, and we can open up for questions.
All right, well, amazing presentations by Dr. Buckholz and Dr. Balakrishnan. So thank you both for coming on today. And then also thank you so much for everyone who attended this session as well. We are so grateful that you guys all took the time out of your busy schedules to join us. And this session has also been recorded and will be shared with the attendees once it has been edited. And then our future sessions are listed on the PowerPoint screen, and you will also receive a reminder about them closer to the meeting date. And then as a reminder as well, for all sessions, you'll log into the iEcho portal to join the meeting. There's also a survey within the iEcho portal, so we'd appreciate it if you would take a moment and give us some feedback on today's session. With that, we hope you all have a wonderful afternoon.
Thank you so much.